Okay. A very good evening, good afternoon, good morning to all the eminent doctors and pharmacists who have joined us. My name is Dr. Kiran. I work as the head of demand generation in Shalina Healthcare, based out of Nigeria. Today, we have a very interesting and very amazing discussion with eminent faculty from Nigeria. The topic of the day today is unfurling the H. Pylori Conundrum with a special focus on H. pylori diagnostic and treatment paradigms. We are from Shalina Healthcare. We are an African company started in Africa and we are 40 years old. We are one of the largest pharmaceutical companies in sub-Saharan Africa. Our mission remains quality, affordability, and availability. All our products are manufactured in WHO approved facilities, and we have a social responsibility where we actually integrate with our vision and value. Shalin Academy does a lot of academic capacity building programs. As you know, a patient goes through many milestones and meets many healthcare practitioners in their arduous journey, whether it's a pharmacist, whether it's a nurse, whether it's a doctor, as well as a community health worker. Shalina actually caters to all these people, all the healthcare practitioners by doing a lot of activities with a special focus on patient-centric approach. This program is actually brought to you by Shalin Academy, where we have done a lot of global webinars across the Africa. And to take this discussion and deliberations forward, we have with us none other than Professor Adamu Alhaji Samela. Sir will be moderating this session. Sir is a professor of medicine and consultant gastroenterologist, Department of Medicine in the Ameno Kano Teaching Hospital, Kano, Nigeria, and also the Bayero University, Kano. Sir's special areas of interest include gastrointestinal endoscopy, H. pylori, peptic ulcer disease, and functional gastrointestinal tract disorders. Sir has got many meritorious papers as well as fellowships. Just a few I want to actually name. Sir has done his residency training program of the West Africa College of Physicians and was awarded a fellowship in 2002. Sir has a fellowship in advanced endoscopy training at the University of Witwatersrand in South Africa and the affiliate Chris Hanning Baragwanath Hospital 2007. Sir has got immense scientific contribution to the field of gastroenterology. Sir has got more than 60 publications in reputed peer-reviewed local and international journals. Sir has delivered more than 100 guest lectures, scientific papers, seminars. Sir has been an external assessor to many universities. Sir has also been a recipient of many meritorious awards. Our next faculty for the day is Dr. Sara Abere. She needs no introduction. Welcome, ma'am. Dr. Sara, consultant physician, gastroenterologist, and hepatologist at the prestigious River State University Teaching Hospital, Arsut from Port Harcourt, Nigeria. In terms of affiliations, Dr. Sara is the Vice Chairman, Medical and Dental Consultants Association of Nigeria. Ma'am is also the chairperson of the Advanced HIV Care Team in Arsut. In terms of professional achievements, Dr. Sara has got an award for meritorious service to humanity at the MD Can. Dr. Sara also holds a PG diploma and MSc in gastroenterology and hepatology from the University of South Wales, UK. Dr. Sara also has a diploma in hospital management from the Nigerian Institute of Management. Dr. Sara has got many certificates in the field of endoscopy, MSSI, from the Korlebu Teaching Hospital, Ghana. Dr. Sara has got a certificate in healthcare leadership from the Lagos Business School, Pan-African University. Dr. Sara is a part of many committees in the River State University Teaching Hospital. Dr. Sara has been a member of several international professional associations, just to name a few, like the prestigious SOGIN, ASLD, AGA, EASL. Welcome, ma'am. Our next faculty for the day is Dr. Owasani Opeyemi. And she also needs no introduction. She's a very eminent consultant gastroenterologist from the Federal Medical Center, Abeokuta, Ogun State, Nigeria. In terms of affiliations, Dr. Owosani is a member of the Society of Gastroenterologists and Hepatology in Nigeria, the SOGIN body. Dr. Owosani is also a member of the American Society of Gastrointestinal Endoscopy, or ASGE. With this introduction of an eminent faculty, I would like to invite Dr. Owosani to give her presentation. Welcome, ma'am.
Okay. Thank you very much for the introduction. So I do not need to introduce myself anymore. I'll be talking about unfurling the Helicobacter pylori conundrum with a focus on the diagnostic and treatment paradigms. So we must understand that Helicobacter pylori is truly a stomach bug. It is a gram-negative flagellated spiral bacteria that commonly infects humans. It affects almost half of the world population, and that's about 4.4 billion people, and is the most frequent and persistent bacterial infection worldwide. The transmission of H. pylori is largely unknown. It's suspected to be person-to-person transmission, and this is either through fecal-oral or oral-oral exposure. Now, the fecal-oral transmission is usually through contaminated food or water. And then sometimes we could have iatrogenic infection through infected endoscopes or nasogastric tubes. It's been identified that there's an intrafamilial cause strain, which emphasizes or which helps to support the fact that it can be fecal oral. So if everybody in the family drinks from the same source of contaminated water, then they tend to get it. So most people in families we tend to discover H. pylori in families. Oral transmission has not been confirmed, but it has been identified that some dentists, quite a lot of dentists, end up with H. pylori infection in addition to their nursing attendants or technicians. So this just shows a time trend for Helicobacter pylori. And we can see there that H. pylori was discovered in 1983 by Barry Marshall and John Warren. These were Australian physicians. By 1994, WHO classified H. pylori as a class 1 carcinogen. And then as we move up to 2012, we find out that the screen and treat strategies have been identified to be effective approaches in the prevention of gastric cancer. Now, this shows the H. pylori prevalence globally and in the African perspective. Globally, Africa has the highest prevalence, followed by the Latin Americans. And in Africa, Nigeria has the highest prevalence, followed by South Africa and the Democratic Republic of Congo. The presentations, commonly H. pylori infection is asymptomatic. But in some patients, they could present with the complications of H. pylori. And this could include a dull or burning pain in the stomach, usually the upper part of the stomach. And the individual may feel, that he's not hungry, he may have a bad taste in the mouth. And sometimes if there's bleeding, they may have passage of bloody stools or bloody vomitus. How is it diagnosed? So we have what we call non-invasive and invasive methods of diagnosis. The non-invasive methods would include the urea breath test, sometimes the stool antigen test, or stool culture. And in some countries, not many, you could actually investigate or do tests on the saliva or urine. And then for the invasive tests, it comprises two major routes, through endoscopy or through blood tests. Now, an endoscopy is a special tube with a camera passed through the mouth into the stomach. And samples from the lining of the stomach can be taken through this instrument. These samples can be sent for histology, where the organism, the H. pylori, can be identified under a microscope. Sometimes the sample taken can be, used for a bedside test. We call it the rapid urease test. Some people call it the CLO test. And sometimes those samples can be sent for cultures, for sensitivity studies, especially where you have resistance to the normal therapy for H. pylori. Then we go to the blood tests, where the antibodies can be detected in the serum or blood. Now, this just shows the trend in Africa for diagnostic tools or methods. And from this table, we can see that it appears Nigeria is the only country that has data on the different methods available for testing H. pylori. A lot of these of the other African countries, either they don't are not available or data is not available. So it shows that there can be a challenge in trying to make the diagnosis for H. pylori. Now the treatments, we have first line, we have second line, we have third line. First line treatment is what most people would give an individual who has been tested and found to be positive. And we have the standard triple therapy that most people are familiar with. Then we have other ways that it can be given. The sequential therapy, where for 5 days, one is given one PPI and then 2 antibiotics. PPI is a proton pump inhibitor. And then for the next 5 days, the same PPI with another 2 antibiotics are given. For the concomitant therapy, we also call it the non-Bismuth quadruple therapy. So these are 4 drugs, including a PPI, that are given at the same time for a certain number of days, usually 10 to 14 days. And then we have the sequential concomitant, which is a hybrid, giving all 4 drugs at different stages. And then we have the Bismuth quadruple therapy. This is Bismuth based, 4 drugs. So it's Bismuth, a PPI, and then 2 other drugs. The second line treatment is used when first line treatment has failed. There's one treatment failure. And these are levofloxacin based triple therapy. So you have a PPI, levofloxacin, and then one other antibiotic. And then third line treatment is when you've had 2 treatment failures. Ideally, it's recommended that we do a culture guided therapy. So culture must be done and a sensitivity pattern used to determine what antibiotics to use for this treatment. The other empirical medications that are suggested are high dose dual PPIs, rifabutin based, and furazolidone quadruple therapy. Now, what are the challenges? First and foremost, and I think highest on the list, is there's an increased rate of H. pylori resistance to antibiotics. We all know that whenever a person has diarrhea or has abdominal pain, the first thing they do is they go to a drugstore to get Flagyl or metronidazole. Sometimes it's Ampiclox or amoxicillin. So there's high resistance to antibiotics. And then lack of measures for control. We've said that transmission is largely unknown, but is suspected to be fecal oral. So contaminated water is a difficult thing to sort out in areas where water is, a challenge. The lack of widespread access to affordable diagnostics tests. Endoscopy is not readily available, and if available, is not readily available. So we do need African treatment guidelines. Thank you very much. And then we're over to the discussion.
Thank you very much, Dr. Wasini, for this lucid presentation. Uh, she has taken us through the history of H. pylori right from the discovery in the early 80s, and 4 decades after, she ended up with the challenges we are facing now, mainly of that of resistance, the lack of sensitivity testing in some of the African countries on some of the diagnostic tests, and of course, the need to have African guidelines so that we can overcome the challenge of resistance and have a sensitivity-based therapy where you have failed regimens. So I think the other panelists and we are live, so I think it's time to discuss this ubiquitous bacteria now that has been with us for 4 decades. A lot have been achieved, and a lot still need to be achieved in terms of growing resistance and how to address them. So, Dr. Sarah, you have for 1 or 2 words to add so that we can start the discussion proper. Dr. Sarah? Dr. Sarah, are you hearing us? Okay, thank you very much. Dr. Sarah?
I can't hear you. The audio is poor.
Okay, so
Audio is poor.
Dr. Owosini, you did talk to us about the issue of resistance. How high is this resistance issue? We know despite the high prevalence of about 4.4 billion, you talk about the half of the world population infected by this bacterium, which
I
has
think we've
become
lost Dr.
ubiquitous.
Smela.
A lot of resistance is there.
Dr.
So
Weseni,
how high is this resistance, Dr. Owosini, across the
okay.
countries, Nigeria and Africa?
Okay, so the resistance, I think it also depends on which country, one is looking at. Unfortunately, I don't have the exact data, but I do know that resistance for metronidazole in Nigeria is quite high. For clarithromycin too, it's increasing. Same thing with amoxicillin. So we have a lot of resistance, and then the resistant patterns in different parts of the country appears to vary. But of note or standard is that the resistance to flagyl or metronidazole is higher than that to amoxicillin and clarithromycin.
So initially, we thought there were no resistance to amoxicillin at all. Amoxicillin over decades after the bacteria was discovered, it remained almost 100% sensitive. But the standard therapy of PPI, amoxicillin, and clarithromycin, which is the legacy, a lot of resistance developed over years to particularly to clarithromycin. And a lot of guidelines have looked at the resistant cutoff of 15%. If you are more than 50% or less than 50% as a nation, that will guide whether you go for clarithromycin-based triple therapy as first line, or you opt for therapy that is not including clarithromycin if you are more than 15% resistance. So I think that has been the guide, and even with that, a lot of failures are recorded in some countries, and that's why the issue of going to concomitant, sequential, reverse concomitant, or the combination hybrid therapy, or even the Bismuth quadruple regimen came into play to address this resistance issue. So I think that's major. I think Sogin has some guidelines, and I'm sure some African countries also have guidelines. It's just for us to sensitize our primary care physicians on the need to be aware to send patients early for checking for this bacteria in terms of the non-invasive test, and where necessary to go for
It's poor
endoscopy depending
humanity.
on the symptom profile. Thank you.
I
So
can't even hear anything.
no, but we are hearing you,
I
Dr.
can't hear.
Sarah.
I keep going off.
That's Netflix.
So I was saying, so in terms of the diagnostic, you did mention about the invasive and non-invasive. Of course, uh, for the non-invasive, we know that the urea breath test is there, the stool antigen, which are readily handy, and of course, the serology for saliva and the other affluents. Also, the invasive one for culture, for the clot test or the rapid urea test or the histology, where you need a biopsy from the stomach to look for the Helicobacter. And I think a lot has been achieved in that direction. So what is the current this in terms of the availability of this in some of these African countries? You did mention that on the graph. I'm sure it's available in South Africa, it's available in North Africa, particularly Egypt. You did mention that most of the countries don't have this diagnostic test except Nigeria. But I think it's available in South Africa, in Kenya, in Ghana, and in Egypt also. All the barrage of invasive and non-invasive investigations. But the major thing is that of resistance, and you need to have guidelines.
Yes. Yes.
Yeah,
So,
yeah. So what do you
yeah,
think?
I agree. They are actually available in most of these countries. The issue is that in some of the in the on the table, you'll find out that when you see NA, it simply means that the data is not available. But we do know that we have colleagues in virtually all these countries that do these tests. So I do believe that the methods for diagnosis are available, but how readily available are they? I mean, are they? Because some countries have just one endoscopist, to serve so many people. And then how many of the patients can have access to this one endoscopist for an endoscopy and then a biopsy. So it's not that they're not available, it's not enough to go around for all the patients. I mean, we have so much of people with H. pylori. I can't imagine one endoscopist serving 2 million individuals, out of which a certain percentage have. How many are they going to, to do? So I believe that it's not that they're not available, it's just that they're not accessible to everybody who needs them. And then where they are, they may not be affordable.
So I think another important issue, despite the 4.4 billion people infected across the world, particularly in Africa and India, we are all aware of the African enigma and even the Indian enigma, whereby there's high prevalence of this bacteria, but there is low incidence of gastric cancer and other sequelae. So is this still a myth or a reality, or is that statement still holds the fact that we have African enigma or the Indian enigma, where people carry this H. pylori quietly and asymptomatic and never develop sequelae, particularly gastric cancer? What do you think about it, Honestly, in terms of the African enigma or the Indian enigma?
Okay, well, I agree. It is an African enigma, truly, because the fact that there's a very high prevalence, and yet the number of people or the percentage of people with gastric cancers are not as high relative to the countries where the H. pylori prevalence is lower. So I suspect there are other things, that may predispose the individual to the gastric cancer, not just the H. pylori. And then remember also that we've talked about the indiscriminate use of antibiotics that is very typical to the African. Rather than go to the hospital and have a diagnosis, they just walk up to the drugstore and they're using antibiotics. On average, I'm sure people take antibiotics at least once a year, whether they need it or not. So maybe this is a protective habit or something, I don't know. But those are my thoughts. I don't know.
So despite the fact that you did mention that the transmission is unknown, but we know that fecal oral or oral, and you said
Yeah,
contamination of
yeah.
poorly sterilized instruments.
Yeah.
We know that there is association between H. pylori infection or acquisition, even at the age of less than 5 years, with poor socioeconomic status, poor hygiene, poor dietary intake, and therefore the poor familial clustering, overcrowding, and poor sanitary condition. Therefore, in terms of treatment, in terms of eradication therapy, from the standard therapy, what do you think is the optimal from 7 days at one point to 10 days to 14 days? So, what do you think is the optimal duration of triple therapy or quadruple therapy for a H. pylori infection for a patient that has not been exposed to treatment before? So, because there is
Let
seven,
me let
10, 14.
me let me take that answer.
All right, Sarah, you're welcome.
Prof himself. Sorry, I went offline briefly. We know that optimal therapy should be at least more than 7 days, because lots of studies have showed that the longer duration of therapy, the better response, the better ability to eradicate. So, but I think that there are other factors that play a role in the success in the therapy. But for me, and from our experience and from several studies, treatment should be at least for 10 to 14 days for proper eradication of the H. pylori bacteria.
So, what do you think is the role of diet, in the role of hygiene, socioeconomic, in terms of control of this bacteria? Because we did mention about socioeconomy and hygiene and crowding.
Yeah. Okay, let me just talk about diets. Okay, there are many dietary substances that tend to affect H. pylori. Some are promoters, some are reducers. It's been found that diets that are high in fats, high in salts, diets that are poor in iron, and even intake of processed meats and have been found to cause an increase in H. pylori proliferation. But for the reducers, things like polyunsaturated fats, like in walnuts, and even use of increase intake of vegetables like broccoli have been found to reduce the proliferation of H. pylori. So diet actually plays a role in the proliferation of H. pylori. High salt intake, which is actually a paramount problem in Africa. We take a lot of salt. It's actually linked to the proliferation or a promoter of H. pylori growth.
So where you don't have a lot of facility for testing, we have the test and treat strategy. We have the treat and test strategy. I want to see where you don't have facility for testing. What will you recommend as empiric treatment for H. pylori eradication for a patient that you suspect to have H. pylori infection and as symptomatic in terms of empiric therapy?
Okay, so if a patient doesn't have what we would call the alarm symptoms, alarm means that there's likely a complication like upper intestinal bleeding or anemia or weight loss. The empirical treatment will be a proton pump inhibitor, amoxicillin, and clarithromycin. I think these are readily available medication that are safe, to use for eradication suspected H. pylori treatment.
So, what is the role of community mobilization, community education, health education, and education of our primary health care workers to be able to address the global acquisition of this bacteria? What do you think we can do at the level of the community in terms of health education, raising awareness on our primary care physicians so that we can stem the tide of spreading of this bacteria in the population?
Well,
Yeah,
probably everything should be tied up as advocacy for me. There's a great role for advocacy because H. pylori is linked to poor socioeconomic status, is linked to poor hygiene. So, for the role of the primary physicians or the healthcare workers, you don't just give your patients treatment. You must advise your patient on rules to prevent reinfection, on what to do to prevent reinfection. And one of them is basic hygiene, hand washing, taking care of the environment, making sure that, you know, they wash their hands before they make their food. And if they're eating outside, they have to be sure of the people preparing that food. If we can have advocacy at the level of the government and improve the standard of living, basically, I think it will help mitigate the increase in H. pylori infection.
So I'm sure you'll also advise our primary care physicians whenever they see a
Mhm.
patient that is anemic, not necessarily having dyspepsia or having symptoms of
Yes,
upper
yes.
GI complaint.
Mm.
What is the special relationship between H. pylori and anemia generally? So that even if the patient is asymptomatic but has iron deficiency anemia, so that they should be able to, and part of the investigation, look for H. pylori and also, depending on this guide other investigations. What do you think? Yeah, we need to guide our primary care physician to consider as part of the routine for anemic patients, particularly iron deficiency anemia.
Oh, well, H. pylori tends to impair iron absorption. We know about that. There have been several studies that have shown that H. pylori impairs iron absorption by causing um, chronic gastritis, which eventually leads to gastric hypochlorhydria. So that impairs the conversion of ferric in, food and other sources to the absorbing form of the iron. So when we see when our patients are at the primary physician, when they see anemic patients, one of the things they should look for is to run a full iron panel, do testing for H. pylori, and even fecal occult blood test to be sure there is no loss through the stool.
So, what is the most feared complication? We all know that they move from acute gastritis, chronic gastritis, atrophic gastritis. Now, what are the most feared dreaded complications of this bacteria that our primary care physician need to know so that they will take the handling and eradication of this bacteria seriously? What are the most sequelae that we dread as physicians that a patient can develop when they have this bacteria on a chronic basis?
Okay, for me, the most important or the most morbid is the gastric cancer because it's something that can actually be prevented if this bacteria is eradicated on time. So we must put that at the back of our minds that this we've already said that it's a class 1 carcinogen. So H. pylori can actually cause gastric cancer. The other things we worry about are peptic ulcers or bleeding, ulcerations, in addition to this malabsorption from chronic gastritis and achlorhydria. So our physicians or general practitioners, community physicians should bear that in mind, that this is one of the reasons we go all out to seek out H. pylori infection and actually treat it, whether the person is symptomatic or not.
Yeah, I think it's very important because this bacteria, because of a linkage with gastric cancer, the International Agency for Research on Cancer declared it as a class 1 carcinogen as far back as
Yeah.
2004, and this statement was reaffirmed in 2009. So it is an important preventable carcinogen associated organism,
Yeah.
and therefore it's very important for us to take that seriously, but particularly in people that have family history of gastric cancer, so that we'll be able to make sure that we
Yes.
document eradication in these patients. Now, in line with that, you did mention about the issue of resistance, and I also talked about resistance, particularly to metronidazole and tetracycline in Africa. Now, another imidazole, the tinidazole. And you can have combinations of tinidazoles, omeprazole, clarithromycin, tinidazole, amoxicillin, omeprazole. And so what is the major advantage, if there's any, of tinidazole-based combination over the conventional, traditional metronidazole-based that we talk about resistance in the past? Is there any advantage of the tinidazole combination?
Yeah, I think there is. I believe there is. Studies have shown that Africa has metronidazole resistance of up to 58 to 95%. And sincerely, someone was just talking to me today. A patient was talking to me today. Say, that's this flagyl. Oh no, yesterday in the clinic. That it doesn't know that flagyl has other uses. So because we're talking that he just takes it as soon as he has diarrhea, just pops one into his mouth, and then of course the diarrhea stops and he stops taking the drug. So the in I don't know how to describe it. The usage by our people, for even irrelevant things has caused a high resistance. So for us, so far there's a high resistance to metronidazole. Tinidazole most likely is a better substitute. It's not been abused as much as metronidazole. Dr. Payemi, I don't know if you have something else to add.
Yeah. In addition to that, it's actually more tolerable.
Yes.
The metallic and nauseous feeling that people have with metronidazole, you don't have it with tinidazole. And then I think the length of treatment is shorter with tinidazole
Shorter.
than
Yes. Yeah.
with
Yeah. It
metronidazole.
is.
So patient
It is.
compliance is better. That's
It's
another
better. Yeah.
issue with treatment, patient
Hmm.
compliance. Yes.
Yeah.
So, but I think one of the things we need to remind ourselves and we do as clinicians is to ability to document eradication. A lot of the time, people either preemptive therapy, empiric, or test and treat, and then patient gets better, and we don't ensure that we document eradication, because that's the only way we can
Yeah.
make sure that we have eradicated the bacteria. We most likely in our practice to make sure that when we give this triple therapy, whether you use 7, 10, or 14 days, whatever, either the first line, second line, or the rescue therapy, whatever you use, you should be able to document that this bacteria has been eradicated, so that you'll be able to assure the patient and reduce the chance of recurrence and the chance of developing cancer or other sequelae in the future.
All right. That's good.
But
That's good, sir.
then sensitivity is an issue. We need to equip our centers to be able to do sensitivity-based or sensitivity-based treatment, so that when you
Yeah. So
have
sensitivity test.
two failed previous therapies, either first or second line, you should be able to do culture-based selection of your combination to be able to achieve success. I think, Suraj, I think we can go live now and entertain questions from people that are joining us live.
All
We've
right.
had, as panelists, I think we can open it for live comments and questions.
And
Uh,
question. All
Thank you.
right. Thank you, Prof.
So if there are people live that want to comment or ask questions,
Prof, there's some questions on the
I'm
question
seeing,
side. Dr. Piran
I'm
has
seeing those
posted
ones.
them.
How long after treatment does a patient take to go to a confirmatory test? Somebody's asking that, isn't it?
Yeah, probably
Yeah.
it's about
So
eradication.
you want
Wants to be
you
sure
want
that
to
the
answer that?
patient is well.
Yeah. Go ahead, Sarah. Go ahead, Sarah, and answer it.
I'm thinking that it should be as immediately after therapy. You want to be sure that your patients responded to your treatment. I think the patient should test at least a urea breath test after therapy. You don't
So he's
No, I
wait
asking
on the
think
patient gets
how long.
reinfected.
He say how long after you finish therapy do you go for the test?
Is there a time frame for it? I don't think there's a
yes,
time frame for it, but it should be as soon
I
as
there
was
is.
saying,
possible.
I
There
was
is.
saying,
I think yes, it's about 6 weeks, 6 to 8 weeks actually.
Our patients
After
will get reinfected.
yeah, no,
yeah,
no,
good.
six
Go
to
ahead.
eight
I was
weeks. Most
go ahead.
guidelines.
Go
Yes.
ahead.
So the guidelines suggest 6 weeks. So
Yes,
six
I
weeks
know.
after treatment. Yes, that's the ideal.
Yeah, the
Ideal
ideal
setting.
thing.
Mm.
But is our
So somebody,
setting ideal? That's my worry.
it's okay. We are getting to ideal. Somebody is asking what are the key considerations in the diagnosis of H. pylori at a primary care setup. I think simplicity and affordability. Somebody is asking at the primary care level. I think major challenge we have in Africa, in Nigeria in particular, is the primary care physicians using serology, which is
Yeah.
virtually useless. I think we need to
Yes.
stress that for
Yes,
that question, sending the patient for serology doesn't confirm presence of H. pylori, doesn't confirm eradication
active
because the
infection.
IgG continues long after you have eradicated. So in the primary
Yes,
care setting, I think the affordability and the availability of the test is very important, and for primary care physician. But we should know that serology is not useful for diagnosis or confirmation of eradication. Then the other question said, "What are your comments on H. pylori and in pregnancy?" Sarah, what is your comment of H. pylori and pregnancy in terms of diagnosis and management?
diagnosis will be the same way we diagnose basically at least a urea breath test, a stool antigen test. Management has to be sure that the patients can. It depends on the stage of pregnancy and if
Yeah.
the drugs are safe for the patient.
Particularly
This stigma should be
tetracycline.
high. Yes, but
Yeah.
it depends on the stage of pregnancy and if they are safe for the patient, for the baby.
Initially there was all this fear that early in pregnancy, PPIs versus H2 receptor blockers. But I'm sure
Yes.
sometimes in pregnancy, depending whether it's category A, B, or C, you need to look at the benefit versus risk
Yes.
in that patient. But of course, tetracycline, because of the epiphyseal affectation in people that are having growing bones, of course, you need to avoid that in pregnancy and lactating mothers because of that. I think that it's very important.
Yeah.
That's that. So somebody is asking, what do you recommend for the treatment of recurrent stubborn H. pylori ulcer? I was saying ulcer, stubborn is described as stubborn recurrent H. pylori ulcer. So
Okay,
what
I
is
think first of all we need to be sure what he's talking
Like
about.
I'm
It's not
telling
it's
you,
not every abdominal pain that is an ulcer.
that
We have to
ulcer.
get that clear. So you must confirm that this is an ulcer, and I think the only way you can do that is an endoscopy. So by the time you
Yeah,
are doing an endoscopy and you're seeing a persistent ulcer, I think you start thinking of something more sinister.
something
Of
else.
course, you need
Yes.
to take a biopsy and then be sure that you're not looking at an early stage cancer before you
Yeah.
say this is just
It's
an
an
H.
ulcer.
pylori
Ulcer.
ulcer.
Yes.
So having said that, if what you are looking at is a stubborn H. pylori infection, not detected by serology, as Prof has, pointed out, because the serology will not change in a long time.
At
It will be
all.
positive
At
because
all.
all you are
Mm.
picking are the antibodies. So if you do a proper either stool antigen test or urea breath test, and it is still positive, then we move from how we've done from the first line to the second line, and then the next best thing is do a culture for sensitivity studies to treat. I
But I
think that
think
would be
in addition to that, one have to consider the patient himself and his habit. Because if there are cofactors like taking of non-steroidal anti-inflammatory drugs,
Yeah.
smoking,
Mm.
alcohol
Mm.
ingestion, taking of traditional concoction, other impediments, or whatever is decreasing blood supply to the mucosa, our patient is malnourished. So many things can contribute to the ulcer not healing, even after you have documented
Yeah.
eradication. But I think most importantly, stoppage of NSAID and the fact that you make sure that it's not a malignant ulcer, so that you take biopsies. Otherwise, if you eradicate and stop NSAID, you should be able to treat these ulcers. But there are what we call giant ulcers, even if they are not malignant, when they are more than three
Yeah.
centimeters. So sometimes giant ulcers, even with all that healing, may take long time. So that's the way to go. Look for other cofactors, drugs, ingestion, either NSAID or traditional, smoking, cessation, alcohol, and all other risk factors, particularly hypoproteinemia or malnourishment in general. So somebody is asking how long does it take to eradicate H. pylori? Can it be ever be eradicated? Of course, it can be eradicated.
It can
And we
be.
did mention earlier that most guidelines talk about 10 to 14 days, even though there's room for 7-day therapy. But I think most guidelines are talking about 10 to 14 days to be able to achieve eradication. What is the duration one is supposed to take PPI after the completion of H. pylori therapy? If you are talking
That's
about,
it.
Sarah, how long do you want to take PPI after you have eradicated H. pylori? Somebody is asking that.
Proton pump inhibitors basically are used for symptomatic relief. So you're treating the symptomatic thing. But I know that 4 to 8 weeks, most patients after 4 to 8 weeks of just PPIs, the symptoms tend to regress. That's what I do. But I think it's symptomatic relief because PPIs are not basically the cure for H. pylori. What it does is to give the antibiotics a conducive pH in the stomach for them to act.
So somebody is asking that do we have H. pylori treatment guideline in Nigeria? If no, why do we hesitate in this all important endeavor only to quietly adopt guidelines from other regions that do not share similar H. pylori antibiotic sensitivity with ours? I think Sogin has done a lot.
It's
Naima has done
entire.
a lot. Dr. Smith in Naima, and
Yes,
we just
yes.
recently launched the H. pylori study group in Nigeria, and
Yeah.
actively very soon the guideline for Sogin
To be
based on
out.
the
Yeah.
sensitivity pattern across the regions of Nigeria will be up for everybody and up on the website of Sogin, and the guidelines circulated to primary, secondary, and tertiary healthcare facilities in the country. So a lot is being done in that respect by Sogin, by the National Helicobacter pylori Study Group in Nigeria, and NIMA has also done a lot of sensitivity and meta-analysis across the country. So very soon Sogin will come up with a guideline. So it's not we are not just
Yes.
adopting from other countries. We are
Yeah.
working on that. So somebody said, can H. pylori infection and its treatment cause IBD, inflammatory bowel disease, or can H. pylori be the underlying cause? There has not been definite link between H. pylori and
There's no
IBD.
link.
IBD remains an autoimmune disease based on a lot of gene mutations, the host and environment, and genetic susceptibility. And somebody is asking, what's the best kit for the treatment of H. pylori infection and assurance in healing? And how long are you supposed to test for H. pylori after treatment? I think we have addressed all that.
We have
Uh,
addressed that.
so any other thing you want to add or what's in terms of what we have been saying?
Well, no, no, no. I think I'm sure there will always be questions, either close to what has been asked or different deviation and all. But I think basically it's just for us to understand and know that H. pylori, like you have said, is actually ubiquitous. It is here, it's prevalent in this environment. To eradicate it in the individual may not be as much of a problem as to eradicate it in the country generally.
Community.
So it's
In the
not
community.
just looking at the individual, we have to look at their families. So having even eradicated in the person, we need to go back and educate them to go back to their families, go back to their communities. So we're educating the individual, we're educating the communities, and we're going to have to advocate for hygienic, or clean, or yeah, clean water, in all our communities, both urban and rural, if we're actually going to eradicate or at least reduce the prevalence to a basic minimum. It can be eradicated really, and I think we just need to be compliant with what we need to do, and as much as possible avoid the abuse of antibiotics so that we don't develop resistance
Discriminate use. Yeah.
yet to what we have available.
So someone is asking, do you recommend routine screening irrespective of symptoms? Routine screening for H. pylori irrespective of symptoms. Just screening
That is
everybody
if
in
the
the
patient is not symptomatic. You're just
yeah,
screening.
just everybody in the population. That's what somebody is asking. What do you think
That's
about
when
that?
you're doing a population-based study because you want
Eh,
to find the susceptibility pattern of the organism. Probably that can be done. But I don't think
Or
we
the
should just.
complications, yeah, or the
Yes,
complications
yes.
associated.
Except patient also has a complication of the infection.
All right. So somebody is asking, what's the role of azithromycin? We talk about clarithromycin, which is a macrolide. Somebody asking,
Yes.
can azithromycin also be used? So they're asking What is your comment about the role of azithromycin? Does it have a place in H. pylori, or is only clarithromycin in the family of macrolide?
Well,
I could hazard, yeah, I could
go on, go
hazard the,
on.
I know, yes, I know that it's in the same family, but was azithromycin was not used or has not been the one used in most of the studies and trials.
Studies, yeah.
Clarithromycin was used. So, but I believe it can be used. But like I said, it's not what was used in the trials and in the studies. So I think we should stick with what has been used, what has been widely, tested. And azithromycin can probably only be used when there's a sensitivity to show that it would work,
That's
if
the response, yeah.
So somebody is asking, is it advisable to add a probiotic? I think probiotic has been discussed across the globe in the last couple of years, whether you can
Yes,
do
yeah.
probiotic supplementation to the triple therapy. So what do you think about probiotic supplementation of our treatment? Does it add value to the sensitivity or to the eradication rate if you add a probiotic to our conventional triple or quadruple or whatever therapy we may choose?
Well, if I want to be theoretical about it, we're doing two opposite things,
Mm,
We're
mm.
giving you an antibiotic and then we're giving you a probiotic. They're probably going to knock off their
One,
effects.
yeah.
So
Mm-hmm.
we will just we have to withhold the probiotics first and at least treat the infection that we're trying to treat. When we've done that, if you must use a probiotic for whatever benefits, you can add that after, you know, the
But
eradication.
but a lot
But,
of studies,
but studies are still ongoing on the use of probiotics in therapy for patients with H. pylori.
but
There have
a lot
been
of studies
conflicting reports, but there are
a lot
studies
of
that are
studies
still ongoing.
in Saudi Arabia, in other parts
Yeah.
of Asia, has
Mm.
been shown
So
some little benefit of adding probiotic to some of these
minimal,
items. Is yet to be adopted globally by all guidelines. But I
globally,
think
yeah.
some societies have shown the benefit of adding probiotics, particularly
Hmm.
in Asian population. So is there any relation between H. pylori and cholelithiasis? Does it have any relation with gallstones? What's in it? Someone asking whether there's any relation between H. pylori and gallstones.
That's not
I am not aware of any
aware.
such. If maybe it's individual, predisposed to gallstones. I
But,
haven't seen any study.
but if you look at it from the place of science of how it causes, it also have some degree of affectation of the antrum and the gastric emptying sometimes. So if for any
Yeah.
reason H. pylori gastritis decrease gastric emptying, the load on the duodenum will be minimized,
Will be
and then
higher.
the
Hmm.
gallbladder empty will be. So theoretically, by extension, there may be some stasis in the gallbladder if the late gastric emptying from the pathogenesis of this bacteria will decrease food emptying to the duodenum. So by extension, I think this theoretically is not it's not an established fact, but I think if you go by that pathogenesis, it may have a link that is yet to be proven. Somebody said, "Is there a link?" We have already addressed some of these things. Can
Yeah.
treatment be can treatment be commenced before endoscopy? Of course, we did talk
Of
about
course.
test and test depending on the patient profile. Is triple therapy safe in third trimester of pregnancy? Sarah, third trimester of pregnancy. Can you use all the drugs?
I don't know, sincerely. That I will send back to the gynecologist to tell me what I can give to their
I
patients.
think I think I
But
think most of the drugs are safe in the third trimester of pregnancy. Most of
I
the issue
don't
we
know.
have are in the first trimester. By the time you're
Yes,
in the
I
third
know.
trimester, I think it's virtually safe in the third trimester of pregnancy. But of course, don't use tetracycline because of the affectation of the
At
baby,
all. Mm.
even during early breastfeeding. Then somebody said that conditions like brucellosis can bring a false positive H. pylori test. Of course, because of the IgG, there's cross activity.
Yes.
So that's why we say don't use serology, not only because of false positive, but cross positivity from other. So it's possible for other
Bacterias.
chronic granulomatous diseases and tropical disease to give you IgG with cross false positivity in this patient. Somebody said, I suggest more awareness on H. pylori has to be created in Africa, especially in our local areas. A lot of them have no idea. And I think there's a lot of idea even among patients about H. pylori. Patient will tell you that
Yeah.
that bacteria is in the stomach. So I think awareness is being created, and this webinar certainly by Shalina, it will go a long way, not only among physicians, even
Yeah.
among patients and caregivers. And the primary care will take it to their patients, patient will take it to their families, family will take it to their associates, I think webinars like this will go a long way in sensitizing a lot of public on this bacteria. Somebody say, is H. pylori hereditary? Or wasn't it? Is it hereditary?
No, no, it's not
No,
hereditary.
it's
What
not.
I said was it was familial. So it's in clusters of families because of their shared water or food or contacts. It's there is no, well, not directly. No, it's not an inherited disease. The only thing we can think of maybe is their success, the individual susceptibility to the infection. So you may
All right.
have that as hereditary. Yes.
So I think the point there is that once the family shared the same type of socioeconomic environment, the same social habit, share this, and there's hygiene issue and overcrowding, definitely there will be familial clustering, not necessarily genetic as per we heard from gene, but from the clustering in the families. I think that's the comment about that. Then somebody is asking, is it part of a normal gut commensal? Is H. pylori part of normal gut commensal, or it's
No,
always
it's not.
pathogenic? Yeah,
It's
it is not a
pathogenic.
normal gut commensal, but not all H. pylori are also pathogenic virulent. So, and that is why you have a lot of people carrying the bacteria, and not everybody develops
Yes,
symptoms.
nothing is happening.
Uh, so it's not a normal gut commensal. At the same time, it's not everybody carrying the bacteria also develop disease. As part of the enigma, as we discussed in Africa and in India. So somebody says, is there a specific PPI for the eradication of H. pylori, or all PPIs can be used? Sarah, is it all PPI or the specific PPI? I think all PPIs are there. You can use all the PPIs once you can use it with 2 or 3 antibiotics as the regimen may dictate. All PPIs would combine with the antibiotics, 2 or 3 can be used. Is there any particular blood group associated with H. pylori? I was thinking, is there any blood group associated with H. pylori?
Yeah, yes, actually, the blood group O, it's not really that it's
Oh, yeah.
associated with the infection, but it's the infectivity. So the people with blood group O's appear to be more susceptible to the H. pylori infection and then maybe failure of eradication.
All right. So somebody is asking, is there any prevalence in children, and are there pediatric formulation to care for same patient? Because if they have it in the children, somebody is asking, maybe it's pediatrician or somebody care for children. Say, what is the prevalence in children, and is there a specific pediatric formulation for eradication to cater for these children?
Okay, I can hazard an attempt to answer that. Yes, actually, the prevalence is higher. Well, I won't say it's higher in children. It's funny that it's actually higher as people get older. But the pediatric formulation will probably be using metronidazole and amoxicillin along with the H2 receptor blockers,
And of course, we
So
have we have we have suspension for children that are young, that cannot take the tablet, isn't it?
yes, yes.
Or
So
the
those are
capsule,
the
as the case
capsule.
may be. Yes.
Yes, that's true. We have some PPIs that come as granules that can be mixed and given through.
Can be
All right.
given to them, yeah.
All right. So are there how common is this in children under 5? I think a lot of studies have shown that before the age of 5, a lot of children in Africa have ingested the bacteria. And so a lot of, if you do seroprevalence among children, a lot of them have been exposed. You get prevalence more than 60% in children already having antibodies that are under 5. Now, how many of them are carrying active infection? You need to do either the fecal antigen or the UBT or to detect current infection. But I think having to do with exposure, either current or previous, more than half of the children by the time they are 5 will show serological evidence of having come into contact with this bacteria. Any other comment about that? About children under 5? Any comment, Awosini?
No comments. No comments. I think you just clarified that when you say H. pylori positivity, is it that they are exposed to it or do they have current infection? So we need
Yeah.
to know we have to be clear about the difference. No comments.
So I think we have exhausted all the questions in the chat box. And if there is any other question going live or comment or other this thing for the panelists, I think we can go ahead. I've taken care of all the questions in the chat box so far.
All right.
Any other comment? Any other closing comment, Sarah or Wasini, so or any other live member or person live that can ask questions, please.
Okay, for me, I'm sorry, my network has just been going on and off.
We
Um,
are hearing you.
yeah, there are a lot of misconceptions about H. pylori in Nigeria. You just see patients just come with that serology test and they say, I have H. pylori. And you ask these patients, do you have any abdominal pain? No. You ask questions regarding symptoms and complications, nothing. But because they just gone to the lab and ran a test, and they just come with the test and they want you to give them antibiotics and they want to be on therapy. And if you don't give them, they still go ahead and buy from the pharmacies. So these are areas where we actually need to look into as specialists and even as primary care physicians. Educate your patients when there is no symptoms and there are no reasons to worry, as per there are no features of complications. You've assessed this patient properly. This patient should not do test-based treatment. Test-based eradication is not the ideal thing. It's causing a lot of resistance across board, and it's causing patients, probably by the time they get infected, what you give them may not even work for them anymore because they've abused this medication. I think that is a very important role for doctors, both specialists, primary caregivers, to emphasize on.
Asking how does H. pylori able to survive the acid in the stomach. I think the major this in there is ability for the bacteria to secrete the urease enzyme, and that urease will convert this into ammonia, urea to ammonia, and that ammonia neutralize the acid, so that the acid instead of going towards pH of 2, 3, or 4, it goes towards 5,
Those
6, or 2 neutrality, and therefore enable the bacteria to grow and survive under the mucosa. I think that's one of the major factors apart from the mucus and the other boring under the mucosa of the stomach. But the urease enzyme and the conversion of urea to ammonia, neutralizing the acid around the bacteria, is one of the major adaptive mechanism through which the bacteria is able to survive the acid. I think that's the question that just entered in the chat box now. Any other
All
further
right.
comment about adaptive something of this bacteria in the stomach? Any other comment I was in or Sarah?
I think you
No,
mentioned
no comments. Again, the only
because
thing we could add that sometimes some are very virulent. In addition to their neutralizing the acidic, components, some are very virulent and are ready to attach, to receptors in the stomach. Despite the acidity and all. That's
Okay.
basically why they survive.
So another question that just came in: how do you differentiate between treatment
Prof, we can't hear you. You have
Prof, we
clicked
can't
your
hear
mute.
you.
how do you differentiate treatment failure from reinfection in H. pylori? Treatment failure and reinfection. How do you differentiate the two?
Probably, for me, I think when a patient has been properly treated, and even as Dr. Washani said, and has been rechecked, and the patient is
Negative.
negative, and then goes back and comes back again with and a brand new infection, that is not treatment failure, that's reinfection. Treatment failure is you've treated the patient, you test, not
Oh
So I was
dear.
saying, yeah.
I think she's okay. She's gone.
So any comment?
Um,
I was saying, any comment?
yeah, yeah. So,
serology.
Go ahead.
okay. So I would say that sometimes it's difficult, except to use the timeline that we have, we have proposed. So after treatment and 6 weeks after you
Can
check
you hear
and
me?
it's still,
We are hearing you. Go ahead. I
yeah.
was saying.
Okay, so after 6 weeks, you check again using the stool antigen test or urea prep test. If it's negative, then we have eradicated at that point. If the person comes, much later after that, and we check again and is positive, then that looks like a reinfection. However, if at the time we're checking to find out if there's eradication and it's still positive, then we take it that that is treatment failure.
All right. So, Sarah, you wanted to say something? Dr. Sarah?
What she says is okay. That was what I was trying to say before my network messed up. It's very windy in Port Harcourt today. So
Okay, somebody's asking uh, for the pharmacological rationale behind certain combination of NSAID and PPI as against diclofenac and mesoprostol for alleviation of pain in ulcer patients. I think you know that the mesoprostol tend to protect the mucosa. So if you are giving NSAID and mesoprostol, it tend to be milder on the gastric mucosa. But if you are using PPI and NSAIDs, uh, it's not the same thing as PPI, misoprostol, and diclofenac. I think there are two different things we are talking about in terms of stopping the effect of NSAIDs on the mucosa if you are giving misoprostol as a mucosa protector, or using PPI to reduce the effect of NSAID in this ulcer when I treated it for a long time basis and eradicated for H. pylori and same. Because some guidelines recommend that if you are giving NSAID for a long time, you need to check for H. pylori in that individual because they are synergistic. If you have both H. pylori infection and NSAID, these are two aggressive factors on the gut. So if somebody is going to take NSAID for a long time, you must make sure that he's not harboring H. pylori. I think it's very important to take that into consideration. But if you give diclofenac and misoprostol, it's just like you're giving a mucosa protector to protect the mucosa from damage from the NSAID. So somebody say, what is the advantage of using tinidazole and amoxicillin instead of amoxicillin? Is it replacing amoxicillin or replacing metronidazole, Sarah? Somebody can use
it's
tinidazole
replacing
and
metronidazole. It's
not
replacing
amoxicillin.
replacing metronidazole. Mm.
So the person is
And
asking,
the advantage
yeah, yeah, go ahead.
And the advantage, we've already enumerated the advantage that the Dr. said, less side effects, more tolerable, and of course, from studies, less resistance.
Yeah. I think the last question, somebody said, when do you test for H. pylori? I think we have mentioned all that. We know that it's
Yes.
associated with gastritis, chronic gastritis, atrophic gastritis, gastric ulcer, duodenal ulcer, gastric cancer, and mucosal associated
Okay, I think Prof's network now is acting up.
It's his turn to get. Well, let's go
it's,
on.
Okay.
yeah, I think we have
Prof, we
exhausted all
lost
the
you
questions.
briefly. We lost you
Okay.
briefly.
Oh, myself?
Yes, we did. Hmm.
So I think we have exhausted, we have discussed extensively. I think we have done justice to the topic and the questions that are asked by audience in the chat box. Uh, if Kiran or Suraj is there or Rahul, I think well, we can round up the webinar if there
The
are no further
section.
questions from the audience that are live, please. Kiran, Suraj,
All right.
Rahul,
I think they're also experiencing network.
no, Kiran is coming up.
It's
Yes,
coming
sir.
up gently. It's coming
Yeah.
up.
Yes, sir. Yes, sir. Sir,
So, Kiran, thank you very much, Kiran.
thank you,
Go
sir.
ahead.
Thank you, sir.
Go ahead,
Sir,
please.
there are a couple of more questions because we have a lot of live audience from Nigeria. So
Yes.
they're eagerly looking forward to interact with you more. So is it okay if we take a couple of questions since we have time, or
Okay.
we'll wind up closing this,
Absolutely.
sir?
They can go ahead and ask.
Okay, okay, sir. Okay, sir. So I'll just post them as well quickly.
You've answered that one.
We have answered the duration of therapy, 10 to 14 days or 7
Yes,
days. We've answered that question. If your
you've
family member is
answered
diagnosed
all.
with H. pylori and treated, going by screen, yeah, of course, you need to screen other family members. That's why we say there's familial clustering, particularly in the family history of gastric cancer, or where there is symptomatic disease in the family. If one family is treated, it's just advised to screen the other family members. Otherwise, there will be reinfection. And also to talk to them about hygiene and how to improve the socio-economic, the general environment to prevent reinfection. or
Yeah.
spray to those that are not infected. I think it's very important about that. I think we have answered the other. Somebody say, what is the
Eh,
worst complication if not treated for gastric cancer or
yes.
complicated the peptic ulcer disease, but the gastric cancer or the lymphoma of the stomach? I think those are separate that we don't want to
And
raise.
it,
Just that,
and even
right.
idiopathic thrombocytopenic purpura has been linked to H. pylori.
Yeah. So, but I think the most dreaded one is the gastric cancer, gastric lymphoma, isn't it?
And squamous cell esophageal cancer.
Yeah. So I think Kiran, I think those are the ones that have come in so far. If there's another one live, let's see it, or the person can talk live if they can or mute themselves.
Yes, sir. Yes, sir.
I don't know if there's provision for that. I think we have taken the questions. We've taken the
Sir,
questions, Kiran.
yes, sir. Sir, most of the questions were actually submitted online as well as through our people who are there with the doctors, sir.
So
I
we have
think,
answered all. We have answered all the questions actually.
yes, sir, yes, sir, yes, sir. Absolutely. Absolutely.
So I think
All right.
we can run off the session, Kiran.
Yes, sir.
So
Yes, sir.
thank you, Dr. Awoseni. Thank you, Dr. Sarah, for this excellent panel discussion, and Awoseni for the earlier presentation. Thank you, Kiran, for the nice introduction. I think this webinar will further sensitize what we already know as clinicians, particularly our primary care physicians, and we'll be able to go back to the community and educate our patients. Also, ask them to go and educate their families, the families to educate their friends, their associates, their neighbors, and their co-workers,
Truly.
as the case may be, so that together we will be able to confront this ubiquitous bacteria and reduce the incidence. If we don't reduce the incidence of the bacteria, at least we can reduce the incidence of the dreaded complications, particularly peptic ulcer disease, gastric cancer, and be able to improve healthy population for overall good of our population. Thank you very much. Kiran, any closing remarks?
Thank you, sir. Sir, I think,
Thank you.
for me, we usually have 5 oceans of the world, but today we see 3 of the oceans of gastroenterology with us. And as always, sir, Professor Sabella, thank you so much with your passion and eager engagement and amazing moderation and your expertise. Thank you so much, sir.
Thank you.
Also, Dr. Sarah, thank you so much. Despite all the connectivity issues with your wealth of experience, thank you so much for being with us and also answering each and every question. We never missed any question, and I'm sure the audience had a great time. And Dr. Ovosinima, thank you so much for being with us for a very lucid presentation and also for all your expertise and comments to answer the questions. Thank you so much. On behalf of Shalina Healthcare, I also want to thank the audience who have joined from so many countries. We will continue to do this kind of webinars, and we will always be here to be associated with you in all the facets of the patient treatment care. Thank you so much, sir.
Thank you,
Thank you.
everybody.
Thank you
Thank
so
you.
much,
Bye.
everybody. Have a lovely day.